Hello everyone, Dr. Matt Ed. Today we'll talk about complications of acute myocardial infarction. The main complications are cardiogenic shock, free wall rupture, ventricular pseudoaneurysm, ventricular septal rupture, mitral valve papillary muscle rupture, RV infarct, acute pericarditis, Dressler syndrome, LV thrombus, ventricular aneurysm. And we'll also talk about its signs and symptoms, its mechanism, the timing after acute MI, treatment. For cardiogenic shock, signs and symptoms include hypotension due to ventricular dysfunction causing organ hypoperfusion. And this usually happens within the first 48 hours of symptom onset, usually in large anterior wall MIs. And the treatment is revascularized within 18 hours of onset of shock, and the interventionist may put in balloon pump, Impella, and medical therapy will be inotropes such as dobutamine or Mironone. And if the blood pressure is really low, like less than 70, we usually start with norepinephrine. And the mortality rate is usually 50% for patients who come with cardiogenic shock in the setting of MI. Another dangerous complication is free wall rupture that can cause hypotension, cardiac tamponade, PEA arrest. This happens in patients without prior angina or MI and in patients with large infarcts, especially those patients with very high troponin. Timing usually occurs within 2 to 6 days after the MI, and treatment is volume resuscitation, inotropes, pericardiocentesis for cardiac tamponade, and then the most important thing is surgical repair. Very high mortality rate. Another complication is ventricular pseudoaneurysm. It is a contained rupture sealed by thrombus in the pericardium, and surgery is advised due to risk of complete rupture, which can cause a free wall rupture. And with auscultation, one can hear the to and fro murmur or see pericardial effusion on echo. Another complication is ventricular septal rupture. It is more common in anterior wall MIs, and one can hear a new harsh holocystotic murmur. During the cath, the pulmonary artery cath will show a step up in the O2 sat in the pulmonary artery and the right ventricle compared to the right atrium. That's because the oxygenated blood from the left ventricle is going to the right ventricle and into the pulmonary artery, whereas it's not going back into the right atrium, assuming there's no severe tricuspid regurg. And this can happen within 2 to 5 days after the MI. Treatment is balloon pump, inotropes, vasodilators for afterload reduction, and surgical versus catheter-based closure. Next complication is mitral valve papillary muscle rupture, and this mostly happens in the posterior medial papillary muscle since it has a single blood supply from the PDA, whereas the anterior papillary muscle has dual blood supply. And this happens in inferior wall MIs, and you can hear a new holocystotic murmur. Patients will be in shock, pulmonary edema. Again, happens within 2 to 7 days after MI. Treatment is afterload reduction with a balloon pump, give vasodilators, revascularize is the most important thing, and possible surgery if it's very severe. One can also see prominent V waves from severe MR and the jugular venous waves. Next, RV infarct happens in inferior wall MI. Patients get a triad of hypotension, jugular venous pressure elevation, and the lungs can be clear since it's on the right side. On the EKG, one can see ST elevation in lead 3 that's greater than lead 2. And you can also diagnose with right-sided EKG with ST elevations in V3R and V4R. Treatment is to avoid nitrates. You can give fluids and allotrope support for hypotension. Other comments include loading up volume, giving more preload to target a wedge pressure of 18 to 20 mercuries. In acute pericarditis, one can see diffuse ST elevation and PR depression, and PR elevation and ST depression in lead AVR. Can happen 1 to 4 days after MI. If it's right after a STEMI, you can use aspirin to treat along with colchicine and avoid NSAIDs, steroids, and heparin, as it can cause rupture from the weak myocardium. After that, we have Dressler syndrome. Patients can get fevers, malaise, pruritic chest pain, ESR, CRP, and pericardial fusion can be found. This happens in 2 to 10 weeks after MI, and you can use NSAIDs and colchicine. In LV thrombus, patients usually get that from large anterior apical MIs, and they usually see an akinetic or disconnect segments on the echo. Usually you check this within 2 days after the MI, and the treatment is full AC for 3 to 6 months. Lastly, we'll talk about ventricular aneurysm. It's persistent ST elevations for greater than 4 weeks, and that's suggestive of it. It can cause heart failure, arrhythmias, or embotic event from clots. And if a thrombus is found, using AC as the treatment or possible surgical resection. And ACE and ARBs can help with reducing the remodeling of the heart. So to prevent this, timely reperfusion and after reduction is needed. Another complication are arrhythmias. After MI and after reperfusion, patients can get accelerated idioventricular rhythm, which we'll talk about later. This usually does not need any treatment and will resolve on its own. And also prophylactic anti-arrhythmia medications after acute MI is not indicated. For some patients with bradycardia, TVP may be needed if there is significant AV block. For inferior wall MIs, it can cause ischemia of the AV node, and patients can get a compensatory response called Bezo-Jarisch reflex that increases the vagal tone. And this is a good prognosis since it's inferior wall MI causing ischemia of the AV node, usually persists within 1 to 2 weeks, and the AV node can recover after reperfusion. For anterior wall MIs, the infarct is part of the distal conduction system, and that is a poor prognosis, and patients likely need a pacemaker. So here we'll talk about accelerated idioventricular rhythm. It is a regular rhythm that's typically, the rate is typically within 50 to 120 beats per minute, and these are usually wide. A QRS duration 120 milliseconds, and there are usually 3 or more ventricular complexes together. The EKG can show fusion or capture beats, which we'll point that out later. And it is typically seen in the reperfusion phase of acute STEMI. It's usually well tolerated, benign, self-limiting. Patients usually are asymptomatic. Important thing here is that the rate is usually 50-120 beats per minute. So this is an example. These are ventricular beats, or you can call them PVCs. And this is it too as well. This is a capture beat. So meaning the QRS is coming through from a P wave. And this is a fusion beat where it's a combination of the normal QRS with the Y complex. So you form something in between. With regards to if a patient needs an ICD, it's only indicated if patients develop VT or VF after 48 hours after the STEMI despite coronary reperfusion. And it's also indicated in patients with persistent left ventricular dysfunction after you go to 40 days after the STEMI. And this applies for patients with ejection fraction of less than 35%, and at NYHA class 2 or 3, or patients with less than 30% regardless of heart failure symptoms. And wearable defib should be considered in high-risk patients for the first 6 weeks after STEMI if there is LV dysfunction. These are my references. If you thought this video was helpful, please like, subscribe, and look out for my next video. Thank you for watching.